It's kind of the State of the Union on ACS and cardiac care and STEMI care for Kitsap County and Harrison. That was your first presentation. And while they queue that up, any other comments, any other questions? What's that? You're welcome. So we're going to be doing this quarterly. So the next one will be June, it'll be September, December, first Thursday. And right now, I'll beg your forgiveness in that I am not going to be here in June. There was a family vacation that was planned before we set this into motion. So that's an obligation I can't break. At least if I want to continue to sleep in my bed. So yeah. So, but I am also in the EMS office most Tuesdays, Tuesday mornings. So it's been kind of one of my personal goals of, one, there are some things that need to get done and get those rolling in some momentum, and also is to be accessible, because that is, I guess, one of the downsides of having a medical director that's not on staff at the hospital that you typically take patients to. So you can't pop in and see me on shift unless you come south and see me at Mason General. So, and then have kind of a regular presence at the office most Tuesday mornings.
So you don't have our back of the heads.
Construction has been delayed for that. They want to maybe move something temporarily. So there's talk about Station 56 for Central K, and that'll be discussed at the next board meeting. So, but right now, so Daniel's there. Daniel Makowicz, she's there usually Monday through Thursday mornings, sometimes an occasional Friday as well, but she's also accessible. Any other comments, questions? Where am I from? I was an Army kid, so moved around a lot, but I did undergraduate at St. Martin's in Lacey, and then went to the University of Washington Medical School. I did my residency in emergency medicine at Darnell Army Medical Center in Fort Hood, Texas. So largest base in the free world, I think still. And then came to Madigan and did my payback for my scholarship. And at the time we had, for a short period of time, there was a combined Madigan and UW emergency medicine residency. And one of the UW graduates came to Mason General, and there was more than one spot open. And he's like, dude, you need to come, you know, as a windsurfer, you need to come, this would be great, you know, and I just, served at the same time. And I've been there ever since, and he left. Yeah, he had set up on a blind date, and she says, like, yeah, and they decided to get married because I'm not moving to Olympia, and I'm not moving to Shelton. I live in Seattle. And he's like, okay, I guess I'm going.
Does it work?
So.
Yes. Okay. Good job.
All right, well, I'll stop killing time, so I'll turn things over to Kim.
Okay. Can I do it casual over here? Thank you. As you know, well, I don't know what you know. I have to apologize. I have been, I had influenza A and everything that went along with it, and I'm still trying to get finished with my steroids and antibiotics. So if I have a little coughing fit, just ignore me. So I wanted to do more and delve more into the STEMIs, but everything got in the way. But this gives you a general overview of how we did in 2018. As you know, in 2017, we were #1 in the state for door-to-balloon time of 47.8, and we are 4th highest volume. What does that mean? Our volumes continue to go up. This year, I think we're at already close to 50 STEMIs, so we're very robust.
Is that from shoveling snow?
Probably, I'm sure. Okay, so. Okay, which one goes which way? This? There we go. Okay, so 2018, Kitsap County saw 109 STEMIs come our way. So, like I said, where to go? We had 184 STEMIs. Last year in 17 there was 171, and in 16 there were 162, and 15 176. So we've kind of been constant. I'm waiting to get to the 200, but not quite yet. All right, so Bainbridge Island, I've broken it down to different agencies. They had 4 STEMI patients. When I compared it to 2015, they had 1 that came to us. 75% were male, 25 female, men 53 and women 70, kind of young for men. There was one gentleman who was in his 30s that threw the numbers off. And day of the week, supposedly more MIs occur on a Monday. So I've tried to see trends, but they kind of were 50% Monday, 25% Sunday, and then Tuesday. Time of day, they were 3 in the morning. That seems to be the most common hours, early morning. And then there was an early evening. At the dispatch patient, I did median times, how long that you were dispatched when you arrived at scene. They were 5.5 minutes, and time on scene was 16.5. They had a lot of LEDs, 50%, some RCAs, and then some CERT. And onset of symptoms, 50% of the people who were there that had symptoms 2 hours or less. It got 75% was 4 hours, and then over 24 is 100. So there was not too many outliers for greater than that. I've seen a week and some like that. All right, Bremerton. That had a total of 116 patients. I think previous in 15 it was something like 11. 44 were female. Percent were females was 73. 50 were males with the age of 60. Their mortality rate, they had 1. It was a female who passed. Interesting, this year, every one of my mortalities has been a female. I think I had my first male recently. We're battling with mortalities. I do the mortalities and readmissions, and our mortalities in November and December and October just killed us, but we had really high volumes. We get quite a sick bunch, and so we're hoping that it's kind of will settle down. So they watch it very closely. I feel like they're my mortalities, so, which I know they're not, but I take them that way. Saturday, Monday, and Thursday saw 3 patients each. Sunday, Wednesday, and Friday, there were 2. Their dispatch patient was 4.5 minutes, and their time on scene was 18.5 minutes. I'd like to say a little bit quicker. Culprit lesions, CERP was 50%, RCA 29, and then just 21 on the LAD. They had 3 arrests. They had 3 that said sudden onset, 1 that was less than 8 hours, and then 1 that was over 24 hours. Over the 24 hours was the female who, her mortality, was our mortality. And then Central Kitsap. They had 25. They still are probably the highest volume we see. 60% were males and 40% females. That's pretty standard for last year. I did see a 10% rise in females that I had not seen since I've done this starting in 11. I don't know if that's related to women are now more aware of signs and symptoms. I do the CARES registry also, and I input over 100 arrests this past year. So I would like to see when I get my numbers, are we seeing fewer female cardiac arrests and maybe more STEMIs? I don't know. They had 1 Takotsubo case. We have more Takotsubo, I think, than what people realize. It's not as uncommon. And then 5 on Thursday, Tuesday, Wednesday, Saturday, and Sunday 4, Monday 3, Friday 1. So there's no trend at all that I see. They had a lot of LEDs, 60%. RC was 35 and circa 5. And they had 2 arrests, 11 sudden onset, 2 less than 8 hours, 2, and less than 24 hours, 2, and then they had 5 over 24 hours, which I thought was really high, which may account also for their higher mortality rate. we're seeing a lot of people that come in and the intermittent they're disregarding, and so I mean, if there was time to get out and do the education, but we did a little bit a couple of years ago, but it looks like we maybe need to start trying to get out there again and do that. In North Kitsap, there were 8 STEMIs, 75 were males, 25 were females, and 61 and 70 the ages, which goes probably pretty much with what's pretty average for the numbers I've seen over the years. And they had one ED needle case because we were too busy. I think in the month of, it was November and October, we saw 25 cases each month. It was odd. We had one day where we got 5 STEMIs, so it was crazy. Days a week, 5 on Tuesday, Monday, Saturday, and Sunday, 1. Sounds like during the weekday you're pretty safe up in north, except for Monday and Tuesday. Maybe. So dispatch to patient was 10 minutes, which makes sense because you guys have Hansville and some of the outlying areas. Time on scene was 11 minutes. A lot of LADs, 3, and RCAs were 4. Had 1 arrest, 5 were sudden, and then less than 4 hours over 2 patients. So, and then I'm not very good at training. Paulsville had 9 STEMIs. 78% were male, and then there was 22% were female. So, but they had a high mortality rate of 22%. And Monday and Wednesday, it shows again the weekdays. No weekends in Paulsville, so you're safe in Paulsville on the weekend. They had 1 Takasubo and had 1 die in the ER. And they had 6 minutes dispatch to patient, and time on scene was 10 minutes. So it was kind of like the rest. They were the 1 arrest in the fields. So there may have been more, actually, but from what I got on my records. Then there was less than 24 hours. There was 1 greater than 24 hours, 1. And then South Kitsap, 16 STEMIs. I think I'd like to be a male in South Kitsap. They had an unreal number of females. 37% were male and 63% were female, and 90% mortality rate. And I believe they were all female. So the days of the weeks, Tuesday, Wednesday, Sunday, Monday, and Thursday, it kind of falls along. Saturday's a busy day there. LAD was 50, RCA was 42, and Circuit 8. Now their dispatch to patient was 9 minutes, and their time on scene was 13.5. They had 4 arrests, and 5 were sudden onset, and then less than 4 were 4, less than 8 was 1, and greater than 1 was 1, and greater than 24, 1. So, I mean, that's just kind of the data. I'm a data geek, so I know some people it puts to sleep, but I do like to crunch the numbers. Any questions?
Do you have countywide totals and averages?
Do I have what?
Countywide totals and averages available?
Yeah, I do. For Kitsap County, yeah, I have whoever. Yeah, I do have, well, we did 103, the breakdown as far as, what would you like to see?
Percentage-wise, as far as what's our actual, because to say that 22% is a high mortality rate in Paulsville.
What, well, that's right, yeah, I agree. And it is, you guys had 3, and it doesn't take many when you've got a small, but a lot of it's not in the field, it's in our area too.
Right, so what I'm asking is, do we have, wow, it's really loud. Do we have those averages and percentages county-wide?
I can get them easy.
Okay.
No problem, yeah.
So that we have a more statistically significant sample.
Yeah. This, I have to say, was put together last minute, so I apologize. It's been crazy. 40% has always typically been 40% on the peninsula, and 60% of the patients come from here, this area. I would like to crunch more, and I may, and give them to put them out, because there's so much more that I could do. I just ran into the time factor. Yes?
Do you compare our statistics with other county statistics to kind of see where we align statewide?
I do not. It's amazing. There's no other STEMI coordinator in the west side but me, and there's one over on the east side. They're starting to, CHI has decided that they're going to make a duplicate of my position for King and Pierce. But when I try and find somebody who has those numbers, it's the data abstractors. And the data abstractors, there's a lot of things they scrub out. And mine's pretty much raw. It's everything I see. And when I went to we have a regional work group for STEMI I went to, and before they had gotten together, they wanted to get everybody's spreadsheet about their STEMIs. Well, they think my worksheet was their spreadsheet. So ours was raw and different numbers, so it was like apples and oranges. But I'm hoping when they get a person for King and Pierce, I can start comparing. Over in Eastern, I have one person. It's Deanna Jones. She's a Sacred Heart. So we kind of do get compare a little bit. But I'm a rare bird. I didn't think it was as rare as it is. But I wish there was. If I did, it would be hard to compare our numbers. Our data abstractors we do, because we do COPE, so we are compared with the state on the data abstracted numbers. And we fare very well. We're always the top. Since 2011 when I started doing this, we've always been in the top tier of our door to balloon time. Mortality, we're rated a little high, but it's trendy. And so what will happen, you'll have a peak and then we go down. So we're below what the national average, but we're in CHI and Franciscan, we're one of the higher. But we do it all at a high risk. We have when you've considered the peninsula and the patients we see, we have a very sick population. They come in pretty sick, a lot of cardiogenic shock. We've got new cardiologists too. We have 3 new ones. One is leaving in May, so that'll give us still one more we need, and an EP. So now, but we've got some young doctors. So that's a growing and learning curve also. So, but the new hospital coming, I had just heard, this is off on a tangent, but they had said they're going to be done with the exterior work in spring, and then they're going to start on the interior in July. So hopefully, we were supposed to open in January of 2020. They think they're going to push back probably to November of 2020. So not too far off. And in the cath lab, they put in the same number of cath labs. They had a couple of swing rooms, but they've already realized that we're going to be short of cath labs. So they're now taking one that was a swing and making it permanently another cath lab. So, as far as STEMI, I've been working with protocol a little bit, and so you may see a few changes. The one thing that Dr. Pulikerthy, do you guys know Dr. Pulikerthy? He's my medical director. Can I talk to him about the opioids? You okay? They have found that when you take opioids for pain control, that slows the gut, which slows the absorption. Well, a lot of these meds that are starting to have you guys give in the field, he's asking, or the cardiology are asking, that you use other avenues if possible, like nitroglycerin, all your other things for pain control. If you cannot, certainly don't let them be in agony, but when you give an opioid, really be kind of sparing with it, because the more you give, the slower the gut goes. You don't absorb the aspirin and some other, and I don't know about the drugs, you probably, yeah.
As far as which ones?
Well, the atorvastatin and the Berlin.
Right.
I don't know if that's.
Is this on? No, mine's on.
Here, Joe.
No,
Oh.
I'll just take mine. Ask from cardiology, and again, that's the art of kind of pre-hospital medicine, and to say I'm going to go right to an opiate or working concomitantly. I think they're really asking us to try to maximize nitrates, given a lot more variety of choice of nitrates for our ACS patients as well in protocol, and not having to just move right to fentanyl or morphine or Dilaudid to even give them an opiate for pain. The gut absorption and motility is supposed and anecdotal. I guess we don't really see evidence to that. I've had other cardiology groups, other centers, and say, well, they get opiates and how can I consent them? my reply back, this is the standard care for acute ST elevation MI, that they go directly to cath lab. And so really the consent is emergent as implied. So the kind of all informed consent for an elective procedure is really a little bit out the window. So that was well received. But I think great numbers and great job through here. As far as the quality improvement issue, it's being recognized that you know, we've asked for hospitals to categorize whether they are PCI hospitals and can they take semis, and put some standards and expectations for pre-hospital care. And then nobody really thought about, we should probably collect some data and look at that. Places have done that independently, and other places have done to a much lesser extent. But this is also then going to be a new focus, really almost statewide, and it probably trickle into the regions of, if we right now took a snapshot of how a region's doing, how a county's doing, how is the state doing for acute cardiac care, can you answer that question? And right now, it'd be a bit of a scramble, for even a little bit for us, but definitely for some other counties that we kind of put that information together. So that's going to be a new focus.
I'm trying to think of how I can get my phone, my number out to them if they want to call. I don't know. The medical officers have it for follow-up. Feel free. I have about 3 or 4 more years around here than I and adios.
Okay.
Thank you.
Thank you.
Thank you.
Let's go ahead and take a quick 10-minute break. Go out. There's a corridor to the brought to you by Paramedic biscuits. So we're going to go ahead and get started. Dr. Hoffman's going to go over some protocol stuff, and then we'll just have some more Q&A, and then we'll wrap up. How many did not sign in yet? Okay.
So yeah, make sure that you're signed in so you can get credit. I think we had another presentation today from Josh Snavely, the stroke coordinator for Harrison, who is now not able to make it. So I don't have specific numbers that Josh is going to have, but I am going to talk a little bit about stroke and some things that I've been thinking about, particularly for Kitsap County. Kitsap County had a great protocol committee that went through and page to page of your current version, which was I think republished after the Northwest regional protocols. And probably was published in 2015, and the regionals it came out in 2014, but somewhere in circle around there. Went through and what would they like to see, what were the changes, and it was a great document. The transition from Dr. Roger to myself was Kitsap County's desire to get back into the regional protocol effort, and so meeting with Mason and Jefferson and Clallam and West Olympic Peninsula. And so we've really tried to then put together a document that suits everybody's needs, is evidence-based, is current, and certainly also reflecting maybe some practices that we're already engaging in every day, but have not been really well documented in protocol and paper. So that's also been a very important thing as well. There we go. So just a sample page, and kind of a look of what we had in the past, kind of algorithm based out, color coded. You're going to see into this a new color for the EMR. So some of the other counties in the region are using EMRs. A first responder for us old guys, okay? In which the scope of that has actually expanded. EMR now is EMT light. They'll be able to give nasal Narcan. They're going to be able to give aspirin for chest pain. They're going to be able to use glucose paste without doing a glucometry check, so kind of how EMTs used to be in the old days, okay? And preloaded epinephrine for an allergic reaction. That's coming out of the national curriculum. So where EMR is being used at, they're being used at volunteer departments. And you can imagine as a volunteer chief that you can say, wow, I can put, I got a guy who works at the tire shop, or somebody who works at a coffee barista, or whatever thing, or a daycare, and I'm about to say, I'm gonna put you through a volunteer EMT course at 160-ish hours, or I can put you through an EMR class of like 55 to 70 hours. And for somebody who's got a day job, which one are you gonna pick? You're gonna pick the EMR, okay, and as a volunteer provider. So you're gonna probably start to see that maybe even as volunteers in some of your other areas, but as interactions if you interact with some other rural districts and volunteer districts. But anyways, things are not necessarily meant to be necessarily sequential, but then you have to lay it out some way, but then this transition of that, what are the BLS or the intermediate responsibilities and what are the paramedic responsibilities. The formulary is still in the back and a nice procedure section into the back. Does it advance? We're right pointing that. There we go. So in national curriculum, big additions or deletions at the paramedic level. There are a few things that are sundowning or, well, if you were sunsetting on. One of those is paracardicentesis and another one is central lines. That have not been removed from the curriculum, but the National Curriculum Committee notes that these are procedures that have not had a huge body utility. It's hard to keep proficient at in the field, and wonder if they have a place still in pre-hospital medicine. Also, without other alternatives for vascular access, is there a need for central lines in pre-hospital medicine? Just a kind of an out there rhetorical question. Okay. Advanced EMTs, adding in bronchodilators, always have had albuterol, but they're adding in anticholinergics, Atrovent, into that. Narcan for intranasal, and I know that that has been something for the EMTs in Kitsap County, but that is something I've asked Joe to start getting training out, so for the BLS providers to give intranasal Narcan for opiate overdoses. Also then for the emergency responder, we're going to be bringing on end-tidal CO2, so not capnography, but just a numeric, and we'll talk about the significance of that for the EMT, how that's going to help you, your BLS partners to help you. Zofran ODT, PO Benadryl, and small volume nebulization with specialized training. So this can also then help maybe burden some of your ALS load, okay? So that patient who's satting well, normal respiratory rate, a little tight, this kind of just change back and forth between you and the BLS provider. Well, he needs a neb, should he go with you? No, they can give him a neb. Okay, all right. Little tummy pain, little vomiting, normal vital signs, they can have a Zofran ODT now for that BLS. Okay. And then EMRs that I talked about, aspirin for chest pain, oral glucose, the nasal Narcan, and epinephrine if it's the preloaded, so it doesn't have to be the preloaded syringes as opposed to the EMTs, which we teach them how that they can draw from the vial and that. So for districts who want to do that, and for their emergency responders, they're going to have to pay for that cost of the preloaded epinephrine. So it's going to be a pretty useful tool. It has a lot of applications in capnography and evaluating your ALS patient, but I think it's going to have some utility for the BLS and identify those patients that maybe need to be at risk and have an ALS upgrade. Everything from code sepsis, usually in cardiac arrest resuscitation, even at the BLS level, okay? And how a patient is ventilated. So I've asked the chiefs, your chiefs, that this is one of the things to ask that they're going to need to buy is to get end-tidal CO2 devices onto the BLS rigs for their on the BLS level. Probably one of the biggest things that we're going to have is this is a little excerpt from what we're, and we stole this from Central Pierce. Well, I stole it from Central Pierce. This is all going to be on our sepsis page. So rather than just sort of gestalt of I think this person's sick, okay, I think this person might be in septic shock, can we get some objective information and basically a score to this? This can be used at all levels, at at the EMR level, the EMT level, and at the paramedic level. And so then there's kind of not so much subjectivity and maybe this argument of how sick they are. So Lou Gladys, who's 74 years old, does not call 911 and say, I think I'm in septic shock. Would you please take me to the hospital? She calls up and says, what? I feel like crap, I'm sick, I'm weak, okay? And how does that get dispatched out to you? Unknown illness, medical eval, unknown sick, general illness. And how's that going to probably get tapped out? Is that going to get tapped out ALS? Going to get tapped out BLS, isn't it? Okay? So we can score this person up and we can find that person who has either too low respiratory rate or too high. That person who's tachycardic, okay? That person has a fever. Their age plays into it. Do they have a lot of pre-existing conditions and comorbidities that go with that? They're a little confused and they're one off. You get a point for that. You're not well oriented to the day, or you're not following commands too well, and you get a point off your GCS. Your pressure sucks a little bit, and then your end-tidal CO2. If we get 9 or higher, this goes into several studies of SOFI data, some of the other pre-hospital studies, and it's a nice tool, and that's why I wanted to use it, because it merges all that data together. So that unknown sick person gets that BLS card tapped to them, and there, and it's like, I've got someone with a sepsis score of 10, and I need an ALS upgrade. So, but also time is precious, so let's get this patient moving, and if it's going to be easier for BLS to rendezvous with ALS, then that's rendezvous, okay? If you have, if elsewhere in the region has, the response has an IV technician, then get an IV going and start some fluid and start some volume, okay? A little extra oxygenation if their stats below 94%. They don't need to be super oxygenated to flood it out with all those extra radicals and over oxygenated. But it's just recognizing that this is a moribund patient and time is of the essence. Yes? So I'm going to be definitely working with Charlie in that this is our, if you will, our simplified version of how we're going to be asking you as the field providers to present this data. And so that when you call in and say, I have a person with a sepsis score of 9, that they know that that's real. It's just as you calling up and saying, I have a STEMI alert, or I have a code neuro. Okay? Questions, comments? And from this, of course, then we'll be looking at volume resuscitation. We'll be looking at that, do they need pressure support, you know? And so, and that kind of non-traumatic shock page that have always existed in there as it dovetails very nicely with that. But also the references on several other pages of, you know, the general illness, okay, the possible stroke, and that bit of a reminder and think of, do you need to think about sepsis? Okay, the abdominal pain, things like that. Those very vague and general complaints that our patients call 911 for. Because like I said, they don't call up and say, I think I'm in septic shock, take me to the hospital.
Dr. Hoffman?
Yes.
Is there going to be like a set number in which like you expect your ALS provider to be transporting these patients, or because I could see how you can get to 9 pretty easy with a patient who's they're septic but maybe don't require immediate volume resuscitation in the field, you know.
It would be 9 or above, and so really you can kind of rationalize away the kind of age and stuff like that, but you're probably going to find that it's going to probably be your pre-existing conditions that are going to add points to them, and like their age. But it's the other physiologic stuff. Then you're probably, if you're not seeing that, then say, okay, well, I just have a really old person who has a ton of medical problems and has a bunch of birthdays, but I'm not having this person that's tachypnic. I'm not having this person who's overventilating themselves, okay, and hypotensive and tachycardic. So it would be at 9 and above. Other questions? Yeah. remote just died. There we go. That worked. Good job. There we go. Good. Stroke. Designation of centers in the state who are large vessel centers, able to do mechanical thrombectomy. Closest to us is St. Joseph's. Majority, obviously, of your code strokes you're taking to Harrison Medical Center. But the kind of identification of then those patients that potentially could have a large vessel occlusion. So we added in the BFAST, so we added in the sudden change in balance and those patients with visual field defects, as well as the face, the arms, and the speech, and still thinking of time of that, trying to get somebody there within 4.5 hours. But then looking for that significant motor deficit is the LA motor score, okay? So that's gonna be that person who has a very one-sided paralysis, face, arm, leg, with that. And these are people that have a higher possibility, or probability, I should say, of having a large vessel occlusion that they're gonna find on their CT angiogram as they go through their code stroke activation. The ask from the state is that if you could get a patient to a large vessel center in 30 minutes, so you're in a 30-minute radius from one of those, you should, and a person who has a positive LAM score, so that's a score of 4 or 5, that should be considered. And I think probably the only jurisdiction I can think of where that was possibly is some parts of South Kitsap.
Yeah, we always go to Tacoma.
Yeah.
Yeah, TG and TG.
Okay, from South K.
Okay.
Okay.
It's 10 minutes
Yeah.
quicker, I mean,
So that'd be also then something that we'll probably be working into our county stroke triage tool that we have to provide to the state of Washington. This is part of our participation in the stroke system for the state of Washington, is how are we going to identify LVOS patients and which of those patients are going to go to LV centers for mechanical thrombectomy. Yes, Mark?
I haven't noticed any criteria for AFib and non-anticoags or anything like that. Is there any of that added to this?
There isn't, and those are obviously great risk factors to think about for these people that have strokes and the TIA patients. But that has not been incorporated into kind of the national tour algorithm. I think that is, though, is great critical thinking, particularly, and everybody's had this. The patient called and I had numbness and weakness and it lasted for a duration of time. I better call 911 and you get there and everything's gone. And they're pretty much back to baseline. And this kind of him and haw, should I go to the hospital or not? I think I want to sign out, I don't think I want to go. And they've got AFib and they're not anticoagulated on that, and that's what you're finding. And these are the people that you really need to kind of do more of a hard press on and say, you really need to go to the hospital with me, or be that's true, but you should go tonight. Because you've had obviously a TIA by definition, you're in atrial fibrillation, you're not anticoagulated. You took an aspirin when you realized that you might be having something bad happen to you today. I love that behavior. You get chest pain, you can't move your left side, but you can find a bottle of Bayer aspirin, you quaff a couple of those, and that's going to save your life, your repentance at that time. Is encouraging those people that they should probably go with you. The other thing that out of this is those hypertensive patients who are having active stroke symptoms. We're going to bring in IV labetalol, and so that we can have that, because these patients are not going to be eligible for thrombolytics until their pressure's down. So if you can start getting their pressure coming down on the road as you're bringing them to their stroke center, then all the better. Okay? Yes?
Is it automatic?
Hold on. Raise your hand if you have a question. I'll bring you a microphone. Thanks.
Just looking at the protocol now, is that something where you're going to want medical control to call for labetalol, or is that just going to be?
No, that'll be a standing order.
They meet the criteria.
Yeah. So it'll be active symptoms and pressures over this. So that, I called 911 because I've taken my blood pressure 17 times and it's over 180 over 105, and I have no chest pain, and I have no stroke symptoms, and I have no visual defects, and that's a person we're not going to give labetalol to, and probably take the batteries out of their blood pressure machine and or disconnect it or cut the cord to it and tell them to go see their doctor. But there's these people who have active stroke symptoms. Yes.
Yeah, I missed what you were saying earlier. Are we able to give this for hypertensive crisis as well, like 240 or whatever? Or
That in, right now, the way we have it written is no. So you could call and ask for a base station order for that.
Okay.
That you have this person who doesn't feel well. It isn't ACS. It's not stroke. They don't have a pulsatile mass in their abdomen, but you're there and they're 240 over 110. And I'm bringing them to the hospital, and can I give them a couple doses of IV labetalol on the way in?
okay.
Yeah. Wow. There we go. Other addition in one of the bigger pharmacological additions is TXA, tranexamic acid, for trauma. So it's been around a time, been around for the 60s, but then started to really get studied here in this last decade. So it's a anti-fibrinolytic, so whenever we make a clot, or our patients make a clot, automatically we want to lyse that fibrin, the protein of that clot, and reuse those products, repurpose them. So TXA then is an anti to that process. So the 60s first kind of used was like for hemophilia, involved Willebrand's. These people with huge bleedings, they'd have real easy access to recombinant clotting factors for those people with those diseases. Abnormal uterine bleeding, crash hysterectomy, okay, kind of common things where they use that. Started doing cardiopulmonary bypass and basically creates this hypercoagulable state. And so they would treat these people intraoperatively with tranexamic acid to keep them from clotting off their graft or their new liver. The orthopedics said, well, you know, we're going to do this procedure. We're going to chop out your native knee, and we're going to put in a couple pieces of titanium, and it looks like something out of, you know, a Saw movie. So can we do something to reduce our operative blood loss? And so they infiltrate the operative site with tranexamic acid. So let's take this out for a spin, and with the CRASH 2 study, and look at trauma. There are some constructive critiques about the CRASH 2 study as far as what kind of patients that they selected in and included in. There's been kind of some of the critiques of it, that it may not always been the best study, but it was TXA versus placebo, blinded, and found that those patients who received TXA had less mortality and less transfusions in their traumatic mechanisms. TXA comes and binds into one of the binding site on the plasminogen side, and then does not allow then this complex to bind, and so no packing, no eating up of the clot. So it doesn't, if you will, make the patient hypercoagulable. It says, don't dissolve your clot, okay? That you're making, your body automatically makes when your patient makes when they've had hemorrhage and trauma, okay? So the CRASH 2 study did 1 gram IV over 10 minutes, and then they followed up with a 1 gram over 8 hours. And so we're going to be looking at a similar protocol into that for our hemorrhage control. Some other anecdotal uses is you can use topically for nosebleeds. So how many people have gone on to a nosebleed who's anticoagulated on warfarin, on Cardax, on Eliquis? Yeah, it's like slaughtering pigs, and it's a bloody mess. Take it in a 10 cc vial, so drop a couple, 2 mLs, 1 or 2 mLs of TXA, and soak it in there on that 2x2 and pinch it off, and more blood's coming down the back of the throat, And after about 10-15 minutes, that is dried up. They use a little Afrin in there as well. It's way sweet. Dr. Churchley tried this at Olympic Medical Center, and then there's been some case reports. These people that have really gross and high volume hemoptysis, nebulized TXA. And he's tried it, and he was very impressed with it. So obviously, you know, maybe how many patients you see in a year who's coughing up, you know, gross amounts of kind of uncontrollable blood. You're kind of wondering about the airway and all that stuff. Not many, but this is something you have in your armamentarium. When I looked at the trauma data in Mason, of, you know, our step 1 and step 2 traumas, and particularly in the step 1s, and removed away those people that were, you know, just head injured, because that's how they made their step 1 criteria. So you looked at those people who were hypotensive and had kind of respiratory embarrassment, and that's what made them into the step 1 criteria. I mean, I had an easy 15 to 18 patients a year would have been eligible for TXA, and that they had blunt or penetrating trauma with hypotension. So I think our numbers here at Kitsap are going to be significantly more than that. So I think there's going to be a great deal of eligibility. Some things we're in the kind of for cardiac arrest, and kind of think about cardiac arrest package. We're already doing high performance CPR. We are great ambassadors for that as well. Kind of utilizing passive oxygenation before getting an airway. The main thing is getting on the chest, high quality to the chest. And I think the thing that's going to be a big saver for us, and I know it's been a topic of discussion previously, but I feel that this is going to be very good, is bringing up mechanical CPR and bringing it up very early. Okay. And so this is another ask that I've brought to your chiefs, is that by the end of 2019, that you have a mechanical CPR device available in every district, if not on every rig. Okay, whatever brand, that's fine, but a mechanical CPR device. Okay, and that this should be coming up and discovering that someone's in cardiac arrest, someone's on the chest, announcing, you know, we have cardiac arrest, so you're mustering a little bit more help. Anterior pads, somebody deploying the mechanical CPR device, brief break in CPR, setting them up, CPR device on, posterior pad, device on, deploy, put it in continuous mode, and that is going to be your first 2 minutes, easy. And now you have someone you hands-free, and so that unknown sick that you get to and find cardiac arrest, and you have your response crew of 3. Heads up CPR also, that can kind of decrease the venous drainage out of the head, because our goal isn't just have ROSC and feel really good that we got a heartbeat back and deliver the patient, but we hope that that patient makes it out of the hospital and goes home for Thanksgiving, right? And our neurological survival, so we're at that. And then also another thing that's really kind of shown is impedance threshold device. So what's motivated me was some data that, really a good set of data out of Rialto Fire. They were sponsored by and heavily involved obviously with a supply company, but their data is very good. And what they found was they put this package together and they had great survival rates. They took any one of these things away. Okay, so this call you're not going to use an impedance device. This call you're going to do manual CPR, not mechanical. That call you're going to do, you're not going to do heads up CPR. Their neurological survival rate went down with just one deletion out of the package. They took out two things instead of one, it went down a lot farther. You added all 5 back together, it went right back up. So that's, to me, is a really impressive cause and effect, and some good evidence. So I think it's worth a spin. Okay? Yes. Assess, is it still positioned correctly and doing what you want to do, something you have. But also now, the person that you had doing chest compressions is now available to start a line, get meds, hook up your, get the ambu bag, because at this point you're probably just doing passive oxygenation to this point, okay, and get ready for those next steps.
Did Rialto test a lot of different mechanical CPR devices, or?
That I don't know. They used they're pretty tied in with Zoll instead of the auto pulse. When I look at the different mechanical CPR devices, I felt that they were equitable, and obviously each have their negative points to it. So that's where I have not had the chief say, you've got to buy this device. I've also encouraged them, obviously, for some big ticketed items of, getting a bunch of end-tidal CO2s, mechanical CPRs, and we'll talk about in a minute, mechanical ventilation as well, that they work collectively and not independently, because the vendors are just going to pick them apart. Other questions? Yeah, Mike.
So are they showing in the studies that anterior posterior pad placement is becoming a better pad placement than both on the anterior?
It is felt that is good for shock delivery. It certainly, it certainly works if you have, somebody who has a total body fat of 4% and as thin as a rail. It's probably not going to make that much of a difference. But if you have a bubble like me, yeah, it's going to make a difference.
So should we start doing that?
Sure.
Well, the other advantage.
Hello. The other advantage to AMP is that that's the only way you can pace if you have a Zoll. You're not supposed to pace. You have to pace AMP with the Zoll.
Yeah.
You can, but you're not supposed to.
Just kind of potpourri of some other things. The spinal stabilization or spinal motion restriction read like stereo instructions in a foreign language. And so we are going to try to have that in a lot clearer, concise in one page. And I think we have that document. Borrow that out of Reno. Mechanical ventilation. If you're much more than about 10 minutes from the hospital and you have your patient intricately intubated and kind of get past that first kind of settling in the ambu bag, it's going to be better served for your patient if they're on a mechanical ventilator. And the farther and farther you are away from the hospital, the more that's true. So that is also another ask that I've had to the chiefs, is that they acquire mechanical ventilators by the end of 2019. Some field ultrasound. Then a few people on the Kitsap committee. There was one person in the Mason committee as well. And there's some great courses out there, and so where training is available. Not all that expensive handheld device that links either by cable or Bluetooth to a smartphone or a tablet. And so for those more remote patients, and then particularly when you're air vacuuming out, that you can get a fast ultrasound exam. And yes, they do have free fluid in their abdomen, and they really do have a pneumothorax. All that better, and the information that you, again, in that continuum of pre-hospital care to hospital care, knowing that. So if that's something that somebody's interested in, that's something that I'm willing to support. Okay. Another thing, I commend the Kitsap committee bringing that, because you're almost, as we brought up, the concept of some palliative care is something that everyone in our region is encountering, in that inclement weather, and hospice didn't make it today. Okay, or we have hospice set up in the intake, but they haven't come and provided, and they haven't come and brought their medicines. You have protocols to treat their pain and treat their anxiety, but you're kind of like, I might do that, and then I'm going to leave this person home, and I don't really have a page for that. And how do I spin that? How do I couch that to the base physician? I'm going to call up and say, I want to give this person a Ativan, I want to give them an opiate, and I don't want to leave them at home. And depending on what base physician you get, you might get orders and you might not. So we want to provide some structure for that, also for some other things as far as using your atropine as oral drops for amyloid secretions. So some people have some personal experiences on call, some people have personal experiences in their own family and friends, but I think it's going to be a good order set.